Thank you, Professor Shireen, for the introduction. Now it's with my utmost pleasure to present our eminent chairpersons for our session, Professor Ahmed Sami, Professor Amr Abdelal, Professor Mona Higazi, Professor Mohammed Mahmoud, Professor Mohammed Bassam, and Professor Sharif Magawer and Professor Zainab Ahmed. It's my pleasure to present our first speaker, and our first talk will be given to us by Assistant Professor Dr. Mohammed Shuraiba, Assistant Professor of Hepatology at the University of Alabama, USA, Birmingham, and a liver transplant specialist.
Good morning, everyone. So it is truly morning time here, and it's not sunrise yet in Birmingham, Alabama. And it's always a pleasure and honor to be here with you. So I am an assistant professor in transplant hepatology at the University of Alabama. And my topic today is about HCC in non-cirrhotic patients. So the state of Alabama lies in the southeast corner of the US, seen here in red on the map. And we pride ourselves for the presence of the University of Alabama here in Birmingham. It was chosen as America's best large employer, something that we're proud of. That's a classification from Fortune magazine. But for us Egyptians in particular, what the UAB is famous for is the presence of Dr. Tinsley Harrison, the author of Harrison's textbook in internal medicine. And he was a native of the state of Alabama, the dean of the school where I'm working at now. And he has a lot of things rightfully named after him, including the Best Teaching Award at the University of Alabama, which I had the honor of receiving that last year. So I have no disclosures related to my talk today. And first, here is some basic information about HCC in patients with cirrhosis. So liver cancer is the 6th most common cancer worldwide, and it represents 90% of primary liver cancers. And it is the 2nd leading cause of death, of cancer-related death. And up to 20% of those HCCs would arise in a non-cirrhotic patient. So here are several risk factors and exposures that could lead to the development of HCC. So most commonly up there on the center, on the top of the screen, is the presence of NASH. So that is becoming the biggest risk factor for developing a cirrhosis and developing cirrhosis in the US in patients below the age of 50, and developing also liver failure needing liver transplant, but also developing an HCC in a non-cirrhotic liver. Viral causes is the hepatitis that we know about, germline mutations, some inherited diseases, and also genotoxic substance that would affect the tumor suppressor genes, including exposure to sex hormones, iron overload, the famous aflatoxin. So we'll dive deep into those causes in our talk. But first, look at that graph there, and it would show you in the dark portion of the column, the portion of HCC that arises on top of cirrhosis. So if you look at NAFLD patients, 65% of those would be cirrhotics. but 34% of those patients will be non-cirrhotic. So that gives you an idea about that 1/3, the big burden of the HCC that would arise from NAFLD. And we do not have guidelines to tell us that we should be doing HCC surveillance on those patients. Maybe we should with the rise in the incidence of NAFLD. Who knows, maybe that will change in the future. So the guidelines are based on the cost effectiveness, and it is felt that NAFLD has still a low incidence overall for causing HCC. Now, we'll look next to that. There is HCV, hepatitis B, alcohol use, and idiopathic causes. Now, our group published on the effect of diabetes on patients that have steatohepatitis, whether it's related to alcohol or related to NAFLD. And we found that the presence of diabetes on its own is a risk factor for development of HCC, as you can see there on the graph. So how does that work? Well, first, it is the most common cause, so you expect to see a lot of non-cirrhotic HCC related to NAFLD. And diabetes and obesity act basically as an inflammatory status that releases cytokines, paving the way to the development of HCC. Common ones would be TNF-alpha, IL-6, and leptin. So metabolic syndrome also, if it's found in other causes of chronic liver disease, including hepatitis B and hepatitis C, it can increase the risk of developing HCC. HCV is another cause. So hepatitis C virus is not really as oncogenic as hepatitis B virus, but yet it can contribute to the risk of developing HCC. The risk is felt to be less than 1% per year, and hence the lack of guidelines regarding surveillance for HCC in those patients with chronic hep C that do not have cirrhosis. So the risk factors would include male gender, age, elevated liver enzymes, the presence of steatosis. Again, you can see here how NAFLD would overlap with any other condition and increase the risk of developing HCC in a non-cirrhotic. Diabetes and alcohol use as well. Hepatitis B virus is quite oncogenic compared to hepatitis C. And there are certain high-risk population that you should be surveillancing for HCC development, irrespective of the presence of cirrhosis. So this is probably the one and only area where we have the recommendations from the AASLD and other societies regarding HCC surveillance. So those are Asian men above the age of 40, Asian females above the age of 50, patients, Black patients, and patients that have family history of HCC. Now, when it comes to patients that have chronic hepatitis B and do not meet either one of those four categories criteria, you can expect also that they would have a risk of developing HCC. So this is a personal practice away from the guidelines. I tend to screen those patients for HCC also. Now, the next thing is hepatic adenoma. It has a risk of about 5% to develop HCC per year. And that risk increases with increase in the size greater than 5 centimeter. Patients that have on imaging telangiectatic changes, male patients are more likely to develop HCC than female patients. And then the development of the beta-catenin mutation. So if we find that on a biopsy that we did of an adenoma, then we lean towards resection of that adenoma. Sex hormones exposure would also increase the risk of developing HCC. So if you look at androgen use in bodybuilders, they do have a risk of developing HCC in a non-cirrhotic liver. And there are two proposed pathways for that, either through development of adenoma that evolves into a carcinoma down the road, or de novo development of carcinoma. And oral contraceptives are associated with a 4.4-fold increase in the risk of HCC in some studies. The fibrolamellar carcinoma, or the fibrolamellar HCC, is a very interesting one. It arises typically as a catastrophe in a young patient. In the past, it was felt to be more in female patients, but more recent study shows that it can affect male patients as well. And it is more common in Caucasians, and it contributes to about 5% of all HCCs that we see here. Surgical resection is typically the treatment there, but it's a notorious tumor known for metastasis and high rate of recurrence of more than 50%. And as you can see in the histopathology there, characteristically, the hepatocytes would line up in layers, and also you see bands of fibrous tissue, and typically large tumor on imaging. So hence the name, the fibrolamellar. Next, alcohol exposure. So it can contribute to oxidative stress in the body, production of endotoxins and inflammatory cascades. However, it may not be that much of a risk in the absence of cirrhosis. But if the patient develops an HCC and they continue to use alcohol, they do have a rapid progression of HCC. And we do see that quite a bit in our practice here. Now, iron overload and other toxins exposure are also causes for development of HCC in a non-cirrhotic liver. And there are several proposed mechanisms for that, but probably the most important one is the mutation of the tumor suppressor genes and oxidative stressors that lead to the development of HCC. Other chemicals include vinyl chloride, methylene chloride, and nitrosamines. Inherited diseases include hemochromatosis, alpha-1 antitrypsin, acute porphyrias, Wilson disease, glycogen storage disease, and Alagille syndrome, which is characterized by the low-lying ears and the butterfly spine, and cholestatic picture usually on presentation. So those are some of the inherited diseases that could lead to HCC in a non-cirrhotic liver. Now, next, an interesting one, which is the aflatoxins. So it is produced by two Aspergillus strains, the Flavus and the Parasiticus, and typically in grains that are stored in hot, humid conditions. So this can be seen in sub-Saharan Africa, Southeast Asia, and China. So any grains that are basically kept in hot and humid weather could allow for the growth of that type of fungus and the production of aflatoxins. And it does lead to mutation of the tumor suppressor gene, the P53, and patients that have chronic hepatitis B are at a higher risk of developing aflatoxin-mediated HCC. So how do we diagnose an HCC in a non-cirrhotic liver? We go through the traditional path there, but keep in mind that the clinical picture is deceiving. Most of those patients will be asymptomatic. They don't have manifestations of cirrhosis or decompensation that will get your attention there. And if you're talking about a limited sensitivity for alpha-fetoprotein, that could be as low as 60% in a cirrhotic, so meaning the AFP can miss 4 out of 10 HCCs. It is even lower in patients that are non-cirrhotic. It could be down to 31%. And then it is normal in patients that have the fibrolamellar type that we talked about. On an ultrasound, the lesion could be hypoechoic, like you see on the top image there, or it could be hyperechoic. And as we all know, the ultrasound is quite disappointing in terms of early detection of HCC. Now, CT or MRI will probably have more sensitivity there, and that might sound redundant to the expert crowd there, but you really have to have the CT or the MRI done as a dynamic, multiphasic, or 3 or 4 phase study, because otherwise, if it's done the traditional way, non-contrast followed by contrast, that may very well miss the presence of an HCC. MRI is more sensitive, and it can show you the fat that sometimes you see in fat-containing HCC. Liver biopsy has a sensitivity of 60% to 93% based on the tumor size. And it can be done in an inconclusive imaging of the patient, or to establish the diagnosis for the purposes of planning systemic therapy or liver transplant. But resection remains really the best treatment and probably diagnostic modality there. And we refer to it sometimes in our tumor board meetings as the big biopsy. A negative liver biopsy does not exclude HCC. Now, how's the treatment done? We just mentioned that surgical resection is the cornerstone of the treatment. It has excellent survival rates, so 96% in the first year. But look at the next line there. The disease-free survival rates are low, meaning that you expect that half of your patients would develop at year 5 recurrence. But remember, we said that those patients have intact synthetic functions. They have a non-cirrhotic liver, so they can always go for a repeat hepatectomy if feasible. Liver transplant is considered in non-resectable tumors or intrahepatic recurrence after resection. So we cannot get those non-cirrhotics listed. We cannot get them exception points for liver transplant. But if they do have recurrence or they are non-resectable, then we can look at the possibility of listing them. Of course, they need to have no macrovascular invasion or extrahepatic spread of the HCC. Systemic therapy with sorafenib and other agents, including mTOR inhibitors, we've tried that mainly for prevention purposes after liver transplant. Not much data in the field of HCC in non-cirrhotic. RFA and TACE are widely utilized, radiofrequency ablation and trans-arterial chemoembolization, widely utilized in HCC in cirrhotics. But I'm not sure that they have the same utility there unless your patient is not a resection candidate. What we're utilizing heavily those days is the use of Yttrium 90 or the Y90, and we find that helpful in particular in that situation here shown on those multiple images. So this is a patient who had a very large lesion and was not a candidate for resection. And basically the patient went for Y90 followed by portal vein embolization just to allow that left lobe to get bigger and hypertrophy. And then at the very bottom in image H there, you see that the patient had resection and the left lobe is showing quite a bit of hypertrophy. So in summary, HCC in a non-cirrhotic patient represents about 20% of the HCCs that we will see. And it is usually presenting in advanced stages, and there are no formal recommendations as to how to surveillance those patients. We all abide by the multidisciplinary approach as per the ASLD guidelines, meaning you really need a room that has a hepatologist, oncologist, IR person, of course, a surgeon, and that usually gives you the best outcome. Surgical resection is the mainstay of the treatment. It offers excellent survival rates. Yes, there is high recurrence, but you can always resect those patients again. And liver transplant can be selected in certain cases as a treatment option, as we discussed. Those are some of my references, and I would like to end by saying thank you to everybody here, and it's always a pleasure and an honor to be with you. Thank you so much.
Professor Shuraiba, thank you so much. With you, Mona Higazi. I'm really honored to be with you again. When I suggested this topic on Hadi, I know that they are the best one can tell us more about the hepatocellular carcinoma on non-cirrhotic liver. Thank you so much. And I want to emphasize that the absence of a surveillance in the fatty liver for hepatocellular carcinoma leading to missing a lot. We need a surveillance program for fatty liver for hepatocellular carcinoma, and especially because the rare one, especially it's almost 10% the fibrolamellar type, but can occurring in young age and presenting when it's already making extrahepatic metastasis. And this is the problem of the fibrolamellar type. Thank you again. We emphasized that we must need a surveillance program for fatty liver searching for hepatocellular carcinoma, even from 18 years and to 20 years, young population with the higher incidence of the fatty liver disease and fibrosis we had in Egypt. Thank you so much for the illustrative, highly structured and scientific lecture. Thank you, sir.
Thank you very much. Well said, Dr. Mona, and it's always a pleasure and a privilege.
Thank you.
Thank you, Professor Mohammed Shuraiba, for this very interesting and elegant presentation. And now, speaking of surveillance programs, our next presentation will be presented by Dr. Mohammed Abdullah, lecturer of endemic medicine at the National Research Center and the medical coordinator of the National Committee for Control of Viral Hepatitis. And he will give us a short talk about surveillance programs for hepatocellular carcinoma.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to express my thanks to Professor Sadiq Zakaria and dear chairpersons, dear attendants. Thank you for your listening. Our talk today will be about HCC surveillance, and we'll make some focus on the Egyptian situation in our lecture. First of all, hepatocellular carcinoma is a major healthcare problem. According to GloboCan 2020, liver carcinoma is the sixth most common malignancy in number of new cases, and the third most common cause of cancer-related deaths globally. In Egypt, and according to National Cancer Registry, liver cancer is the most reported malignancy, with about 23.8% of cases. The prevalence in males are a little bit larger than females, 33 versus 13%. According to GloboCan 2020, also liver cancer is recorded the highest malignancy in number of deaths, about 29.8%, and in incidence about 20.7%. There are many risk factors, as mentioned by Dr. Mohammed in the previous lecture, and of course, in our region, HCV is recorded the highest cause of malignancy. It's about 44%. The annual risk of developing HCC in HCV-related cirrhotic patients is about 2 to 8%. And when HCC occurs, the rate of cumulative recurrence is known to be 70% over 5 years. Therefore, a global action plan needs to be taken, and in 2016, WHO has launched the global strategy targeting viral elimination by 2030. This program was not only aimed to deliver medications to treat HCV and HPV, but also it stated that in addition to antiviral treatment, chronic care is required, including management of decompensated liver disease and the hepatocellular carcinoma. Therefore, Egypt has launched since 2006 an ambitious program through the National Committee for Control of Viral Hepatitis in 2006, with many successful steps, such as introduction of DAs at 2014, introduction of generic medication in 2016, and reaching the achievement of presidential initiative campaign at 2018. This campaign was able to screen more than 48 million Egyptian citizens, and it reported that there is HCV prevalence declining from DHS 2008 15% to 5% in 2018. But would that make a change in the magnitude of HCC dilemma in Egypt? A study was predicting the numbers of HCC patients recorded that if this study was at 2015, and it said that if we were able to treat 1 million cases in the next 4 years with a decrease of incidence between 2016 and 2020, it will be the best scenario for the future estimates for HCC. And I think we are on this track, inshallah. But this massive treatment raised the issue of the dilemma of HCC and direct-acting antivirals. Is there a relation between both of them? And according to a many Egyptian review, it stated that there is a conflicting results regarding the risk of developing HCC after DA exposure, and it may be due to geographical and ethnic variations and differences in design and inclusion criteria among the studies. And as we can see, there is a huge discrepancy between the results of all studies included in this review. Additionally, another study, Egyptian study, reported that there is a successful management of HCV in previously treated HCC, but there is a high rate of recurrence was observed, especially in the first 6 months of treatment initiation. And therefore, it's recommended that surveillance in cirrhotics should be continued even after achieving SVR. Now we are shifting to the surveillance in between EASL guidelines and ASLD guidelines, being the most widespread guidelines of the world. Are they agreed on the points of surveillance, or there is a difference between both of them? The first question, who should be screened? According to EASL guidelines, screening is usually done or recommended to all cirrhotic patients, child A and B, and the cirrhotic patients, child C, if they're only on liver transplantation list. There is another recommendation, as Professor Muhammad said in previous lectures, for non-cirrhotic HPV patients and non-cirrhotic F3 patients based on individual risk assessment. And the rule of surveillance for patients of NAFLD without cirrhosis wasn't unclear. But on the other hand, the ASLD guidelines agreed on the main terms like EASL. It recommends surveillance to all cirrhotic patients except child C, unless he is on transplantation list, given the low anticipated survival for patients with child C cirrhosis. And the risk of HCC is significantly lower in patients with NAFLD without cirrhosis, and it's also agreed that surveillance is not recommended for these patients. What is the preferred screening interval? According to EASL, interval should be dictated by rate of tumor growth and the incidence in target population. And stated that 6 months is a good and reasonable and cost-effective period. And stated that if we do a 3-month interval surveillance, it will be has no clinical benefit. And 12-month surveillance may be lead to fewer early-stage diagnosis and shorter survivals. Additionally, ASLD agreed on the same term, and it recommends every 6 months surveillance. But it stated that modification in surveillance strategy based on etiology and liver disease or risk stratification model cannot be recommended at the time. This is another study that compares the time interval according to different guidelines, and most of them agreed on 6 months interval for screening. So, what's the preferred screening tool? According to EASL guidelines, it preferred to use ultrasound is the main method of choice. The serological tests are not currently cost-effective according to EASL guidelines. Tumor biomarkers for accurately early detection are still lacking. On the other hand, ASLD added alpha-fetoprotein for the recommendation and surveillance, and stated that alpha-fetoprotein is expected to increase the sensitivity of surveillance ultrasound. And despite of the high performance of dynamic imaging, CT or MRI, but it's not cost effective to use them in surveillance. According to novel biomarkers for surveillance, alpha-fetoprotein L3 and DCP are both a new novel biomarkers for use approved by FDA for risk stratification, but it's not until now approved for using for surveillance. There is a diagnostic model called GALAD, which incorporates alpha-fetoprotein L3, DCP, according with patient age and sex, does a promising results in phase 2 studies, but larger studies needs to be done to approve it for usage. There is no much difference between EASL and guidelines in the diagnostic algorithm for surveillance. The main issue was that we need to focus that if there is a suspected lesion less than 1 centimeter, according to EASL, it's recommended to repeat it at 4 months. If it's stable, we will still on the surveillance. If there is a changing pattern, we will move to further steps. ASLD agreed with that also, and it recommends repeating ultrasound in every 3 to 6 months instead of 4 in EASL guidelines. So what's about cost effectiveness of surveillance program? Both guidelines had agreed that the decision to enter patient in surveillance program is determined by the level of risk for HCC, while also taking into account the patient age, overall health, functional status, and the willingness to apply and comply with surveillance requirements. The level of HCC risk, in turn, is indicated by the estimated incidence for HCC. Cost-effectiveness studies indicated that incidence of 1.5 per year or greater would warrant a surveillance in cirrhotic patients is effective irrespective of its etiology. But in patients with HPV, the incidence it will be 0.2 per year. In general, an intervention is considered effective if it provides an increase in the longevity of around 100 days. Interventions can be achieved at a cost of less than approximately $50,000 per year of life gained is considered a cost effective. And the several published decision analysis cost-effective results has approved that surveillance is generally a cost effective. And therefore, EASL guidelines has encouraged implementation of screening programs to identify at-risk candidate populations. And such programs is a public health goal, aiming to decrease HCC-related and overall liver-related disease. And therefore, Egypt has, after the surveillance, success in the HCV treatment program started in 2019, we started a national surveillance program for hepatocellular carcinoma in patients with liver cirrhosis. The patient who is offered a free visit every 4 months where abdominal ultrasound and alpha-fetoprotein tests are used to screen for HCC. This program is not dedicated only for HCV patients, but it expanded to cover all the causes of cirrhosis. Suspected cases are electronically referred to specialized centers for dynamic imaging or to multidisciplinary teams for the management. I hope this program will succeed as the HCV program, and for sure all patients with liver cirrhosis and patients with non-alcoholic fatty liver disease, as Professor Mona said, needs to be done, has to be surveilled under surveillance program. And thank you.